Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Yatin Mehta, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, FRCA, DNB, FAMS, FICCM, FIACTA, FTEE, and chairman at the Institute of Critical Care and Anesthesiology at Medanta, Gurgaon. And today, sir is going to discuss on a topic initial resuscitation in sepsis. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you very much, Faraz, for inviting me. It's a pleasure to be here. Dr. K.K. Agarwal used to be a dear friend of mine, so remember him fondly, and his activities continue after his demise. I'm going to talk about an interesting topic: initial resuscitation of sepsis. All of you will be treating sepsis, even if you are working in a peripheral hospital, when the patient comes to you, you will provide the initial treatment and then maybe shift to a secondary or tertiary care center if need be. So this is a case-based presentation. So let's begin. We had a 65-year-old female with a history of diabetes and peripheral vascular disease who came to the casualty with painful right legs for 5 days. She had a minor injury there about a week back and followed by fever. There was a tachypnea, difficulty in breathing, and inability to stand because of pain. There were no other major complaints, and she was a known hypertensive and hypothyroid, and no other comorbidities. Systemic examinations, so she was tachycardic, febrile, hypotensive, tachypnic. Chest, nothing specific, cardiovascular normal, abdomen was normal. The leg showed erythema, it was warm to touch and it was tender, and there was some crepitus on the soft tissues. Q SOFA was 3 by 3. By Q SOFA is basically meant for assessment of the patient's severity in the emergency or in the ward, but not in the ICU. But these patients obviously needs to be shifted to the ICU. This is what the leg looked like to an examination. So, a provisional diagnosis of sepsis with septic shock secondary to necrotizing fasciitis was made. Well, we did the arterial blood gases, which is what is recommended, and we had a patient with acidotic, uh, hypoxemic, uh, base X was -9, so acidotic. Sodium was low, 127. Potassium also borderline low, 3.7. Lactate was almost more than double what is normal level, and anion gap was 8.4. So, what would you do next? Well, there are 5 1 hour bundle, 5 things in the 1 hour sepsis bundle. Measure the lactate levels. So, you take a sample and remeasure it if lactate is more than 2.2 to see how your therapy is working. Obtain blood culture prior to the administration of antibiotics, which is general recommendation everywhere. To begin with, you can begin with broad spectrum antibiotics because we don't know whether it is a gram positive or gram negative sepsis. And you'd start fluid resuscitation. And generally, the surviving sepsis 3 guidelines is administration of 30 mils per kilo of crystalloid in the first 3 hours to basically bring the lactate down. And still, if the BP remains low, then you start vasopressors. The goal is to keep mean arterial pressure over 65. So, what's the first step going to be? So, we resuscitated with fluid, with plasma light solution, with the help of a pressure bag through a peripheral line initially, and supplemental oxygen was started because the patient was hypoxemic. The next question which comes is how much fluid should be giving and how fast the fluid should be given. So this is the surviving sepsis 3 guidelines. I happen to be one of the co-authors, and I represented India and ISCCM in this. So the recommendation, which is the best practice statement, sepsis and septic shock are medical emergencies, so start immediately the resuscitation. And again, the recommendation was 30 mils per kilo of crystalloid fluid in the first 3 hours of resuscitation. So this was what the X-ray, plain X-ray chest looked like. and the IVC was collapsing. I'm sorry, the image is not coming in this. And on CT scan, the it was a B profile lung. So patient was a bit hypovolemic. So restriction of now recommendation many times is don't give too much of fluid because it's bad for every organ and primarily for the lung because there's interstitial edema, it will get worse, lung compliance will get worse, oxygenation will get worse. So this was a classic paper, classic trial, and published in NEJM, the randomized controlled trial, and this concluded that among adult patients with septic shock in the ICU, IV fluid restriction did not result in fewer deaths at 90 days than standard intravenous fluid therapy. So earlier recommendations were you do fluid restrictive therapy, but now there is not enough evidence to show that. And this was another paper, again, Clover's trial, a classic paper, National Heart Lung Institute, uh, early restrictive versus or liberal fluid management for sepsis-induced hypotension. So this was a multi-center randomized unblinded superiority trial, and this concluded that among patients with sepsis-induced hypotension, the restrictive fluid strategy that was used in this trial did not result in significantly lower or higher mortality. So basically, both these trials show that it doesn't make a difference whether you give more fluid or restrictive fluid. Now, next question which comes is which fluid should we be giving? Should we be giving any crystalloid, or should we be giving saline, or should we give colloids, or should we give normal saline or balanced solution? So let's see what the surviving sepsis guidelines say. So we recommend using crystalloid as a first line fluid for resuscitation. Which crystalloid to give? Well, we suggest, mind you, this is not we recommend it. It's a weak recommendation. We're using balanced crystalloid instead of a normal saline for resuscitation because recently a few papers have come which have not shown any significant benefit of a balanced salt solution, particularly in a country like India because the cost of balanced solution is a little bit more. But all of us know, I'll come to that a bit later. Smart trial, this was a smart trial, balanced solution versus normal saline. There was a lower 30-day mortality, zero point 0.8 balanced solution. And secondary analysis of smart trial showed a reduced 30-day hospital mortality and major adverse kidney events at 30 days was less and increased number of days without vasopressor. So in this study, smart trial, balanced salt solution was superior. But this was a large multi-center Brazilian trial. Flavia Mercado is one of the co-authors of Surviving Sepsis Guidelines. She has a lot of publications. And there in Brazil, they compared balanced solution with normal saline because Brazil also has a similar economic challenges as India. And they concluded among, and this was again published in JAMA, among critically ill patients requiring fluid challenges, use of balanced solution compared with normal saline did not significantly reduce 90-day mortality. So there was no particular benefit of balanced salt solution. A few objections and flaws in the study, but I won't get into that. Coming to albumin and blood or blood products, what does it say? Again, surviving sepsis guidelines say it's a weak recommendation. We suggest using albumin in patients who receive large volumes of crystalloid. Now, what do you call a large volume of crystalloid? Well, that is not specified, but it does make sense because since the oncotic pressure will go down if you give only crystalloids. So, if you give a large amount, in my experience, large would be anything more than 2-3 liters, then you give albumin. This was a major study, again published in NEJM, albumin replacement in severe sepsis, 1,800 patients, randomized controlled trial, multi-center trial. What did they find? During the first 7 days, uh, higher mean arterial pressure was maintained when albumin was administered and lower net fluid balance because positive fluid balance after a first initial resuscitation can be detrimental. There were other, and for coming to other starches, which became quite popular in between, but for sepsis, they are no more recommended. So we recommend against using starches because meta-analysis showed that it increased the mortality and increased the necessity for renal replacement therapy, that is dialysis with starches. So these were the two major trials. Risk of death is also borderline increase, and RRT was also significantly requirement increased. So how do we monitor? Once you give a fluid, when does the resuscitation end and maintenance fluid begin? So we suggest using dynamic measures. You should not see central venous pressure or pulmonary capillary wedge pressure, mostly in the cardiothoracic centers. They are static measures. You measure one at one point of time, so you have to look at a trend. But so we recommend dynamic measures, which are a continuous measurement over static parameters. Now, what are the dynamic measures for Indian circumstances? I would recommend passive leg raising test is the best to use because it costs nothing. But yes, you have to have some device to measure the stroke volume or cardiac output. If the patient is on a mechanical ventilation, you can with a tidal volume of 10, at least 8 to 10 ml per kilo, then you can look at systolic pressure variation or increase in stroke volume variation. If it is more than 12%, it is significant. That means this patient is fluid responsive. Because if the patient is not fluid responsive, if you give him fluid, it is not good for the patient. So, a few meta-analyses have showed reduced mortality with dynamic measurement. ICU length of stay was shorter, and mechanical ventilation duration also was shorter when you did dynamic assessment of fluid responsiveness. But again, this was another paper, Devil's Advocate, Mitch Levy's group. They showed that there was no significant difference in mortality between septic patients resuscitated with a volume responsive guided approach compared with standard resuscitation strategies. But again, this is not the standard of care. At the moment, the way it stands, you should have the dynamic measurements of fluid responsiveness if, uh, if you have the facilities. So, coming to septic shock, which suggests guiding resuscitation to decrease serum lactate. Now, earlier surviving sepsis 2 guidelines 2016 uh, were giving more importance to lactate. Now, it's not that important, but you need to look at the trend of lactate. Uh, it's an important biomarker of tissue hypoxia, lactate, venous lactate. But again, there are too many variables of which can affect the lactate. That is cardiac output, and peripheral perfusion, and vasoconstriction, extraction of oxygen, and so on and so forth. You do not need to achieve a normal serum lactate, but at least the trend should be towards normalization. And there was a Neuromed made a shock trial which showed that capillary refill time, which is much easier to do and cost anything, was superior to serum lactate guided therapy. So this was the endometrial shock trial, based on which the surviving sepsis 3 guidelines recommended for adults with septic shock. We suggest using capillary refill time to guide resuscitation. So if you press the fingertip and you then release it, it should become red in 2 seconds, refill in 2 seconds. If it is more than that, then peripheral perfusion is not good enough. This endometrial shock trial showed its superiority. But yes, this is again, if the patient is very dark skinned, this may not be very easy to assess. So whatever you do, you measure do frequent measurements of the various variables. What should we do along with everything else? What you're doing? Send blood cultures. You should administer the antibiotic after you've taken cultures, and always send, along with the other relevant cultures, you should send blood cultures. So this patient received doses of injection, meropenem, clindamycin within the first 1 hour. But it is multiple studies have shown that within 1 hour administration is much better. So again, as surviving sepsis guidelines, we recommend patients with a high likelihood for sepsis administering antimicrobials immediately, ideally within 1 hour. And this study, multiple studies have shown early administration reduces mortality. This large study in almost 150 New York hospital of 50,000 patients, each additional hour led to increase in mortality of administration of antibiotics. Again, this image is not visible, but IVC was fuller after the initial boluses. So as the patient remained hypotensive after initial resuscitation, we started vasopressor to maintain mean. Our goal was to maintain mean arterial pressure over 65. So, is there any pressure targets? Yes. We recommend an initial mean arterial pressure of 65 over higher mean arterial pressure. There was a large study which did show compared 65 to 70 with 80 millimeters of mercury and did not show any particular benefit of higher mean arterial pressure. And again, a meta-analysis by Hallens et al. Did not show any benefit of higher mean arterial pressure. So, which is the drug of choice when you have to give mean arterial pressure, maybe in a peripheral hospital? Drug of choice in septic shock is norepinephrine. Okay, and what other vasopressors? Let's see that. Now, these are the recommendations. A meta-analysis of 11 RCTs showed that norepinephrine does show reduce the mortality and has a lower risk of arrhythmias than dopamine. Dopamine is generally not recommended. Um, if norepinephrine is not available, then you can give epinephrine. Or worst case scenarios, dopamine. What are the problems with dopamine? Dopamine has a higher incidence of higher mortality and higher tachyarrhythmias, death due to tachyarrhythmias. Therefore, initially, if you have nothing else, you can start dopamine in a peripheral infusion, but then you have to change it as soon as possible. So this patient continued to be hypotensive despite high dose of norepinephrine. So what does one do? What are the vasopressor to increase the pressure, perfusion pressure? Well, vasopressin would be the next drug to give. So we suggest adding vasopressin instead of in escalating doses if doses of norepinephrine are escalating. This is based on primarily on two studies, Vanish trial and VAST trial, both of which showed benefit of adding vasopressin to norepinephrine when the doses of norepinephrine are high. What about monitoring? Well, we do suggest invasive arterial pressure monitoring, but don't delay therapies because of invasive monitoring is not available. And do not delay administration of vasopressors like epinephrine, norepinephrine, or whatever, because you don't have a central line. You can begin a diluted solution through a peripheral line in a large cannula, in a large vein, preferably the cubital vein or above the elbow, and start it. And let the ICU guys or whatever till you have the facilities, but begin your therapy in a peripheral line immediately. The risk of extravasation is a little overemphasized. If you give it for diluted form for a short time in a peripheral line, it really doesn't matter. So this patient was continued to remain hypotensive. Vasopressin was added in addition to norepinephrine, and we inserted invasive central line and arterial line. So patient who still require vasopressor, we suggest adding hydrosteroids. That is, steroid of choice is hydrocortisone. A meta-analysis has shown resolution of shock is faster, and three trials major trials, adrenal trial, approaches trial, and Vanish trial, have shown that hydrocortisone does help, and the recommended dose for hydrocortisone is 200 milligram as a continuous infusion or intermittently, that is 50 milligrams 6 hourly till the shock resolves. This patient, then on investigation, the hemoglobin was a borderline low, white counts were high, neutrophils were high, um, urea creatinine were raised, LFT also were borderline elevated liver enzymes. APTT again was raised, INR was 2.7, D dimer was borderline raised, procalcitonin was 17. Um SARS-CoV-2 RT-PCR was negative. Urine showed the bacteria and pus cells. Ultrasound abdomen showed grade 1 fatty liver. Um, 2D echo, global hypokinesia 45% EF. So, working diagnosis of necrotizing fasciitis with multi-organ dysfunction with septic shock was made. Within the first 4 hours of ICU admission, patient became agitated, extremely tachypneic, oxygen requirement went up, so we intubated patient. The patient started spiking high fever. So repeat PCT was increasing, 28 uh, nanograms, and this is what it looks like. So we did a bedside fasciotomy because unless there is a source control, sepsis, severe sepsis cannot be controlled. Antibiotics will not take care of that. Patient remained stable on vasopressors, which were tapered over the next 2 to 3 days. Culture showed pseudomonas, which was resistant to most of the drugs except colistin. So we added uh, colistin. Patient, this was the X-ray looked like. Patient was extubated after 6 days and shifted to the ward after 5 days. So what are the key takeaways for initial resuscitation of sepsis? Early recognition is vital. Don't delay the recognition. The diagnosis should be established in the emergency room. Early and aggressive fluid administration is essential to restore intravascular volume and improve tissue perfusion. Administer appropriate broad spectrum antibiotics without delay, depending upon the suspected system involved and whether the patient has been hospitalized recently, has a high risk of multi drug resistant organisms, or is coming from community. Conduct a thorough assessment to identify and treat the source of infection promptly. As I said earlier, unless the source is removed, it may be intra-abdominal sepsis or empyema or cellulitis and fasciitis like this. Unless you take care of the source, the antibiotics will not be efficacious. Maintain mean arterial pressure over 65. Use vasopressors. Initially, you can start norepinephrine, and still, if you require, you can add vasopressin. Initially, begin with uh, peripheral line till you get a central line in, but do not delay administration of vasopressors to maintain mean arterial pressure above 65 because of absence of a central line. So, you can give it diluted form in a large peripheral vein. In refractory septic shock, if the patient is still septic, consider early administration of corticosteroid. Obviously, I would presume that you would have done an echo to rule out significant myocardial dysfunction because septic cardiomyopathy is also a recognized entity. And adjust your interventions based on the patient's response to treatment. So I thank you for your attention and I'm happy to answer any questions.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participant on their practice also. Sir, I can see, sir, we have received some questions from the participants, sir. If you allow, with all your permission, shall we take these
Yes, yes,
questions?
please.
First question is from Dr. Ramakant, and he is asking what are the current recommendation for the type and volume of fluids to be administered during the initial resuscitation of septic patients.
See, I've answered that in the first few slides, if you remember, but I'll repeat it for this thing. See, at the moment, the Surviving Sepsis 2021 guidelines recommend administration of 30 ml per kilo within the first 3 hours. But see, again, there has been a lot of discussion and debate about this. So what is the recommendation is give aliquots of say 200 mils and reassess after 500 mils how the patient is responding. And then accordingly you can increase or decrease your resuscitation fluid, which fluid to give. Basically, as again I said, crystalloids are preferred, but normal saline, you must understand, is not normal saline, it's abnormal saline. The sodium content and chloride content of normal saline is 154, which is much higher than the plasma levels. Therefore, balanced crystalloids are preferred. But again, if your cost is an issue, ringer lactate is not that expensive a drug to use. So use ringer lactate because normal saline is not the best outcomes.
Thank you so much, sir, for sharing your insight on this question, sir. I hope that Dr. Ramakant has received his answer. We have another question from Dr. Sunandana, and she's asking, when should vasopressor therapy to be initiated in septic patient, and what are the first line agent recommended by the current guidelines? What's your point of view on this, sir?
Again, I have covered that, but initial vasopressor of choice would be norepinephrine. And then, if the shock is still refractory, that means not responding to escalating doses of norepinephrine, then vasopressin is the drug, a second drug to be added. Occasionally, you may use, if these are not available, you can use epinephrine, and dopamine should be the last resort, but it is still better than not giving anything. The second part of the question is, when do you start vasopressin therapy? Well, I would think that within half an hour or an hour of your fluid resuscitation, if the patient's mean arterial pressure is not improving, that is the time to start vasopressors.
Thank you so much, sir. We will be taking one last question from Dr. Subramanian. He is asking, what are the common challenges in achieving effective source control, and how can they be addressed in the initial management of phase? Sir, what's your point of view on this?
See, if the source control is like this, if there's an abscess which is visible in the say extremities or something, that can be drained even in emergency. You don't have to wait for the patient to be seen by the general surgeons and then taking clearances and taking him to the operating room. That takes too long. If there is an empyema, you can put a chest tube there in the thing. So at least the source control is done. Interventional radiology, if you have the facilities in a tertiary care center, then you call them earlier. If a particular abscess or collection has to be drained, but yes, earlier you do the source control, the better it is. Like in this patient, we did the patient was too sick to be taken to the operating room, so we did a fasciotomy the bedside. But yes, source control is important. Unless the abscess or empyema or whatever you have is not taken care of, you will not antibiotics will not be able to control the ongoing infection.
Thank you so much, sir. I can see one feedback from Dr. Ramakant. He is asking, wonderful lecture, and thanks for answering my question. And thank you so much, sir. As I can see, sir, there is no more question from the participant. I hope, sir, you have done justice to this topic and you have covered all the points. And it was really great, sir. As there is no more questions, sir, with all your permission, shall we conclude this session for today?
Thank you. Have a good day, all of you.
Welcome, sir. And we would like to see you in future also with different topics, sir. Till
Absolutely.
then, take
Sure.
care of yourself, sir. Have a
Okay.
great day, sir. Thank you.
Thank you. Thank you.